Cardiovascular disease is very common in Hong Kong, and it is often a silent disease caused by a number of risk factors. And the most classic triad of risk factors include high cholesterol, high blood pressure, and high blood glucose, in other words, diabetes.
Of these three, cholesterol is actually the most important risk factor in the genesis of heart disease and strokes. So why do we develop these risk factors? Why does our cholesterol go up?
Cholesterol is divided into good and bad cholesterol. And the bad cholesterol is also known as low-density lipoprotein cholesterol. And it is actually quite essential in our body formation because the membrane of all our cells in the body are made of cholesterol. And also, our sex hormones are also made by cholesterol. In the most important clinical trial finding, we find that coronary heart disease in people with type 2 diabetes, the single most important risk factor is actually not high glucose, but it's the high LDL cholesterol, in other words, the bad cholesterol. Well, because in people with diabetes, their cholesterol molecules are a little bit different than yours and mine without diabetes, because their particle size is a lot smaller and denser. And that means that they are more atherogenic, which means more toxic to the blood vessel than the large and puffy one.
There are different levels of LDL cholesterol that we should be aiming for different types of people, different risk levels. So, for example, if you're someone who doesn't have any diabetes, doesn't have any other risk factors, just a person with generally healthy body, then your LDL cholesterol level should be kept at maybe below 2.6 millimoles per liter. Now, if you have some minor risk factors, like just high blood pressure, just diabetes, for example, you might want to lower your LDL cholesterol to below 1.8 millimoles per liter. If you have a problem, you've had a heart attack, you've had a stroke, you've had an operation, bypass grafting or stenting to your carotid artery or to your heart arteries, then you're at higher risk. So your LDL cholesterol should be controlled to less than 1.4 millimoles per liter. In addition to cholesterol, sometimes I test for other what we call non-classical risk factors as well. So we talked about the triad of high blood pressure, diabetes, and high cholesterol. What other non-classical risk factors do you usually test for as well in some certain patients?
In my practice, I like to look for lipoprotein little a. This is a genetic marker, as you know very well, which is very similar in its molecule to LDL cholesterol, except that it is not altered by diet at all. It is altered by your genes, or you're born with it. So that's the reason why you might see some of the youngish patients in their 30s or 40s, and they have severe coronary plaques despite not having many classic risk factors. If you check their Lp(a), maybe it is elevated. And it is really frustrating because there was not a lot you could do in the old days in terms of drug therapy, because this is genetically determined. But currently, as far as I know, there's some new drug therapy which can affect its level.
And also there's this issue with lipoprotein little a that you mentioned just now. What kind of therapies do we have these days to treat high cholesterol and to treat lipoprotein little a?
The new injectable medication, what we call PCSK9 inhibitor.
Statins are the bedrock of therapy for high cholesterol. They've been around for the last 30-40 years now. They've been proven to be effective. There are some limitations to statins. Sometimes they are not so effective in certain people, especially people who have genetic resistance to statins. Even if we use high doses of statins, sometimes people don't achieve their target levels of LDL cholesterol. And the higher dose of the statin you use, the higher the chance of side effects.
In my practice, I actually see a lot of new onset diabetes. A lot of patients come to me and after their doctors put them on a really high dose statin and their sugar and just cross the line and from pre-diabetic become diabetes. And therefore, sometimes I would just look at their liver and see whether fatty liver could be a reason. Very high risk, they really cannot do without their statin or PCSK9 drug therapy. How would you advise them? What would be a more practical solution in terms of helping them not to miss their therapy? Otherwise, something acute may occur.
A small interfering RNA therapy, which is a way of interfering with the production of a molecule that recycles the cholesterol receptor on the surface of the liver cell. In short, it enhances the recycling capacity of the liver so that the liver will absorb all the cholesterol from the blood and then remove it from the blood, and then you get rid of it in your bile. This injection is a once every 6-month injection.
We've talked a lot today about cardiovascular risk factors, and the focus was really on the bad cholesterol. And it is very important for us to be aware of what our cholesterol is in terms of preventing future heart disease. Key message from a primary care physician, and that would need to be frequent checking of your cholesterol level and treat as necessary to the desirable level by the appropriate therapy.
Now is the time to go and see your doctor, screen for all these risk factors, screen for cardiovascular disease, and get it treated if necessary. Consult your own doctor.